Wonderful. So welcome everyone. For those of you who I don't know, really great to have you here. My name's Darryl O'Donnell. I'm the CEO of the Australian Federation of AIDS Organisations. It is obviously a really extraordinary moment for us all in public life, in our communities, and as a sector, as organisations, as professionals responding to HIV, to viral hepatitis, to STIs. We're not only concerned about COVID-19 in terms of the impacts on those we care about, we provide care for and work with, but we're also concerned about how to sustain effectively a response to HIV, to viral hepatitis and STIs, how to sustain that response effectively during what's going to be a period of really profound social and economic and health system disruption. So for all of us, we've got really important leadership roles in that, and so it's great to have you here. Today is really an opportunity for us to hear from some very eminent leaders in our sector, but also in the wider response to COVID-19. And I'll introduce those people in a moment. Just in terms of some housekeeping, and we've got a large number of people on the call. We've already hit 100. As has been mentioned, we're recording this so we can share it with others. There'll be a lot of people trying to dial in who won't be able to join. But we will share this widely. But just to manage the number of people on the call, please keep yourself on mute if you're not speaking, and please use the chat function if you'd like to ask a question or send a note to me or to everyone on the group. I was just on a call earlier on, and the chat function is really, really helpful. If you're hearing things in the discussion where you go, I know something interesting about that, or I've got a reflection on that, use the chat function to let everyone else on the call know your thoughts. We do want to create a lot of time and space for questions and for discussion. And so our speakers are here to give their wisdom and their insights and their perspective, but also to hear from you and to be challenged by you in terms of your questions and about both the clinical and the science and the epi and public health issues that are all in our mind, but also about where this is going and how we make sense of this and what it means for us as communities and as community service providers and as clinicians. I should also introduce Alexis Apostolellis, who I'm sure nearly all of you know, who's the CEO of ASHM and who's co-hosting this meeting with AFAO.
Super, thanks Darryl. Hi everyone.
And also Kevin Marriott, who's the acting CEO of Hepatitis Australia and likewise is co-hosting this meeting. You're on mute there, Kevin, but there you go.
Good morning, everyone, or afternoon, depending where you are. So.
Great, thanks, Kevin. So welcome. So what are we trying to do today? We're really trying to create a space where all of us are informed and well armed with the kinds of information about COVID-19 that help us to do our jobs as professionals, as community leaders, as clinicians, in working with HIV, hepatitis and affected and communities and people living with HIV and viral hepatitis. So when we're talking about communities, we're thinking about those living with, we're thinking about sex workers, we're thinking about people who use drugs, all of those in our communities who look to us to lead on responses, not only to HIV, but to the wider health issues and concerns that affect them. And so we want to hear about the science and the clinical implications, but we particularly want to think about those in ways that are relevant to our communities to take that next step. All of us are watching the media very closely. Just to let you know who's on the call, we've got clinicians, we've got many workers from the community sector. Huge welcome to all of them. We've also got colleagues from sexual health services, from public health units, and also from government, from departments of health, hopefully at the Commonwealth level, but also in states and territories. I say hopefully from the Commonwealth. We did invite, just given their leadership role and the work that they're doing in terms of the public health response, we did invite them to have a speaker, but that was always with the understanding that that would be unlikely given the incredible demands that are on them in terms of their work in the National Incident Room. So that's the approach. We'll turn to each of our speakers. We're going to give them about 7 minutes each to tell us a little bit about this from their perspective. we'll have some time for some quick technical questions, and then at the end we'll hopefully have enough time for some discussion to hear your questions. But first of all, can I just introduce Sharon Lewin, Professor Sharon Lewin, who's the head of the Doherty Institute. Sharon really doesn't need much introduction, because if you're following the media, you're seeing a lot about Sharon and a lot about the work of her team at the Doherty, who are really right at the heart of the response to COVID-19. But Sharon, of course, is an amazing leader in our sector as well, here in Australia and globally, in terms of the search for a cure for HIV. So it's wonderful to have you, Sharon. Can I hand over to you?
Yeah, sure. Thank you, Darryl, and thanks for hosting this. Really important. The more information we could get to people, I'm hoping the greater comfort we can give to people and not panicking, because that's really concerning me at the moment. As Darryl mentioned, I have been immersed with coronavirus. As I said to someone yesterday, I feel like I'm sleeping with someone else, as in I'm no longer with my favourite virus anymore. I haven't abandoned HIV, but as a virologist and someone that's very interested in public health and in all the system response, and of course leading the Doherty Institute, you know, it's unavoidable that many of us are being really engaged in this response, and I think all of us have got a lot to offer, because some of the experiences, both scientifically, amazingly enough, and in public health and in the social consequences of something like this, to me, I draw on so many lessons from HIV. So I've been asked to give you a briefing on the science, like a coronavirus 101. I'll keep it very simple and just talk about treatment, vaccine and prevention, and maybe diagnostics, because actually cure is not really an issue here. People clear coronavirus. It's not like HIV where it persists indefinitely. And I'm going to do that in 7 minutes. So coronavirus is a totally new virus. We have not seen this virus before, just so that people understand the different terminology. People call it COVID-19, which is the illness caused by this coronavirus. And the virus itself is called SARS-CoV-2, which, to be honest, is totally complicated and a real mouthful to get you to talk about. But that's the virus, and the illness is COVID-19, a little bit like HIV is the virus, AIDS is the illness. I'm going to just call it COVID-19, even though that's a really naughty thing for virologists to do, because it's not the virus. But SARS-CoV-2 complicates it because people get confused. And I'm just going to call it COVID-19.
No, it's exceeded the number. You want to sit here? Because this is all from the Doherty Institute.
I think you're going to need to mute your lines, everyone.
Getting to speak.
Yeah. Could everyone mute their lines? Because I can hear other people talking. Sorry. There's some conversation there. So just mute your lines, yeah. So COVID-19 is a coronavirus, and it is a totally new virus, but we know quite a bit about coronaviruses because it comes from a family that we've had experience with before. And first of all, coronavirus can cause a common cold. That's the ones that we see every year. But we know that coronavirus can cause severe illness in 3 settings, which is SARS, which you would have heard about, which appeared in 2003 and disappeared. MERS, which appeared in 2012, Middle Eastern Respiratory Syndrome, largely in Saudi Arabia, still grumbling along. And then this new coronavirus, COVID-19. And they share some similarities, but there's actually a lot of differences. And the main reason why this one is so much more serious is not because it causes more disease or more deaths. It actually causes less deaths and less severe disease than both SARS and MERS. But it's got this ability to transmit very easily and to transmit from people who are relatively well, mild symptoms, or even completely well. And as I often tell lay audiences, you know, the viruses do really well when they can transmit from someone that's completely well, and HIV is the perfect example of that. Obviously, people off treatment in HIV can transmit for 10 years when they're completely well. And so this coronavirus has become very tricky to deal with because it's transmitting largely from people who are symptomatic, we think, but we can definitely find the virus in people that are completely asymptomatic. And that just might mean that many more people are infected than we know, and they've successfully cleared the virus. But it makes it very tricky for tracking down cases and stopping transmission. And just as a comparison, in SARS, SARS, a very similar virus, actually 75% similarity between SARS and COVID-19. But SARS made people very sick, and only people that were very sick were transmitting. So you knew exactly who should be isolated. And so isolating people, putting them in hospital until they had cleared the virus, effectively shut down transmission. And SARS came and went over a 6-month period and only affected a handful of countries. And caused similar illness, far higher mortality. SARS had a mortality of about 10%, COVID-19 1 to 2%, and you'll hear a little bit more about that from Edwina. But SARS only was transmitting when people were very sick, so it was easy to contain. And so that is the trick that this virus has now learnt, and therefore allowed it to travel all around the world. The sort of scientific, just very quickly, where did it come from? All of these coronaviruses are found in bats. This coronavirus, very similar virus, also found in bats in China. And rarely do these viruses go straight from bats to humans. They have what's called an intermediate host, and we don't yet know the intermediate host in this coronavirus, COVID-19. But now that we've got widespread human-to-human transmission, that's probably academic, but we don't know it. So the big areas for science are in diagnostics, treatment, and prevention. Diagnostics, you hear a lot about this because testing is so important, and it's an area that people in the HIV community know enormous amounts. The current...
Because I've got the video off.
Could everyone just please mute their lines? Thanks a lot. And so there's a lot of work done on testing. At the moment, the test is basically like a viral load test that you know of, people have in blood for HIV. We do a viral load test, but this time we have a swab of the nose or throat. And we're only testing people currently in Australia who have symptoms, who have returned from overseas in the last 2 weeks, or have been a contact of someone with known COVID-19, or who have severe pneumonia. And there's a lot of work being done is, can we simplify the testing, like rapid tests, point of care tests, all the stuff that was being developed for HIV is now being looked at in coronavirus. Because if we had a simple point of care test, like a pregnancy test, or just like our point of care HIV tests, that would really simplify things, but we don't have that yet. I just heard on the today Thailand is evaluating a point of care test. You may hear about the difference between a blood test and a throat swab. A throat swab is what we use now. It's the viral load test. Blood test is an antibody test, same as HIV. This would tell us if you've been exposed and therefore likely immune to coronavirus. Those tests are just coming online. Westmead apparently have a test for antibodies. That'd be really helpful. Not at all to diagnose people that are infectious, but to diagnose people who've been exposed and have cleared the virus, and they're therefore potentially immune. So it could really help us in deciding who should be working, or very important for healthcare workers, and very important for us understanding the true distribution of the disease. Treatments. Treatments are often not talked about a lot in the media, but in fact would be an extremely important part of the response. You'll hear later that 80% of people have very mild disease and don't need treatment, and 20% of people get into hospital, and 5% will go into intensive care. And so we need treatments that block the virus from replicating, and therefore could potentially reduce transmission, again, very much like HIV. Treatment as prevention, and people are looking at that. We need treatments that stop people getting sick, so stop them getting severe pneumonia, stop them getting into intensive care, and stopping them from dying. That is really a high priority. And the front runners for treatments are antiviral drugs And all the work that we've done on RNA viruses over the last decade is all paying off, because the front runner drugs for COVID-19, which are in clinical trial in China now, are drugs that work on other RNA viruses. One of them is a drug that was developed for Ebola, but is being tested for COVID-19, a drug made by Gilead called remdesivir. Bit of a hassle to give because it's intravenous, but randomized clinical trials underway now in China. The other drug is Kaletra, interestingly enough, only Kaletra, not other protease inhibitors, and it's lopinavir that has anti-COVID-19 activity in test tube models. And everyone got that idea because it also works for SARS and MERS in test tube models and in animal models. And there's big clinical trials in China and now in the US, and we hope to establish one in Australia too, of Kaletra. And then there are some other, a new flu drug. Flu is also an RNA virus, just announced yesterday, that reduces viremia, and a handful of other drugs. The other area of therapeutics is drugs to dampen the immune response, because that's probably what gives you this severe lung disease. And finally, prevention. I'm not going to talk about public health. That is 100% the best way to prevent getting infected. Andrew will talk more about that. I'm going to talk about other ways for prevention, and I think of it exactly like HIV, vaccines, and maybe even PrEP, actually. So vaccines, a lot of vaccines are in various stages of development. There are 3 front runners right now. And one of them is from University of Queensland, which uses a protein, which is basically a conventional vaccine platform, but a fancy way of making those proteins. Actually, that group is looking at HIV, looking at HTLV1, and now using that platform for COVID-19. And they're hoping to be in clinical trials by the middle of the year. They're very advanced. They've had a lot of support to get to this point. And then there are 2 other vaccines, again, very well characterized in HIV, DNA vaccines or RNA vaccines using the genetic code of the virus. And the RNA vaccines, there's never been a licensed RNA vaccine. This may be the first. There's a whole lot of things that make RNA vaccines look good. The first phase 1 study for an RNA vaccine just started, I think, yesterday. We're doing a lot of work on this at the Doherty Institute, got at some alternative vaccine platforms that are in earlier phase development, and we've received quite incredible philanthropic support to promote that work, or to start that work. And then finally, PrEP. There may be an option of a drug that prevents infection, and that would be or even antibodies that prevent infection, very similar to what you'd be familiar with in HIV. What we would need, of course, is a safe and easy to take drug. So it can't be remdesivir because that's intravenous, but people are looking at other possibilities like chloroquine, and a drug. Maybe, these antiviral drugs are easier to deliver or get out quickly, especially if they're already licensed compared to vaccines. So I'll stop there and happy to take any questions or wait till the end of the session.
Wonderful, Sharon. Thank you so much for that briefing. It's incredibly informative and very helpful. I can see we've got a couple of messages there, and in fact, some of those things you've actually touched off in terms of antivirals that are promising for COVID-19. You talked about PrEP. One of the questions there is about reinfection and what we know about reinfection with COVID-19 at this stage. Is that something you could comment on?
Yeah. When you clear COVID-19, you make a really good antibody response and a good immune response. In fact, a group here just published that work yesterday. Very exciting. First description of the immune response to COVID-19. And does that mean you're protected? Well, we know from SARS, and they're very similar, as I said earlier, that in an animal model, SARS wasn't around long enough to really answer this question in people, but in an animal model, animals were protected from reinfection for a few months after infection. So it may not be lifelong immunity like we see in measles, for example. We don't know the answer to that question, but there will be immunity potentially for a few months.
Great, thank you, Sharon. There's a couple of other questions coming through, and this might be one for either yourself, Sharon, or Edwina, just in regard to the flu vaccine and the importance of the flu vaccine for people this year, but particularly people who might be less well, who might be immune compromised. Could you comment on
that? The flu vaccine has no activity against COVID-19, first of all, except what we don't want is for people to get infected with both viruses. And in China, about there was an instance of about 8 to 10% co-infection with flu, which it would be a bad combination. So we definitely recommend flu vaccine for everyone, and particularly for people living with HIV, as we do every year. And so particularly important to comply with that. You asked me another question. The second half of that question was?
Flu vaccine and for people who are immunocompromised. And,
oh, yeah. And the issue of disease in the setting of HIV and immunocompromised, I'll leave to Edwina. The short story is we don't have any data on that, but Edwina will tell you the same thing, I hope, unless you know something I don't know, but there's nothing out there.
Sharon, thank you so much, and we will throw back to you at the end, but that's a wonderful segue to Associate Professor Edwina Wright, who we're also delighted to have on the line as one of the leading clinicians in our sector and long-standing supporter and ally of the response. Edwina, can you talk to us about what this looks like clinically and in particular what it looks like for not just for people in general, but also for people in our communities?
Yeah, thank you very much. And it's really great to be here, and thank you for hosting it, and also thank you, Sharon, for having given us such an excellent overview and hugely important perspective, because it seems, I think, perspective is everything in terms of managing the community and the appropriate response. What I like to do is to give an overview, and the overview is that I'll talk briefly about the natural history of COVID-19, about HIV and other bloodborne viruses in relation to COVID-19, and challenges that are facing people living with HIV and other bloodborne viruses and people at risk of bloodborne viruses, and finally challenges facing our healthcare workforce. So as Sharon explained, the SARS-CoV-2 virus causes the COVID-19 illness, which is a respiratory illness transmitted by droplets either directly in the air, which we inhale, or we can self-inoculate ourselves with the virus if we accidentally touch a surface that the virus is on. And data are coming out now about the longevity of the virus on different types of surfaces. The commonest symptoms are fever, fatigue, and a dry cough. And as Sharon said, fortunately, about 80% of infections are mild to moderate and can be managed at home. But about 15% are more severe and people become hospitalized. And about 5% of infections are critical, requiring intensive care support. The dynamics of transmission are such that it really seems to require close contact, so that in China about 65% of infections occurred in the family setting where people are clustering together. And it's thought that if you have close contact with a person, that around 1 to 5% of people will a close contact with a person who's symptomatic with COVID-19, about 1 to 5% of people will acquire the illness. And we can talk later about what the definition of close contact is. The key predisposing factor to this disease is age, with a huge weighting towards being older, such that nearly 90% of infections are seen in people between the ages of 30 and 80. The other key predisposing factor seems to be comorbidities, and one of the first published reports from China of inpatients, patients hospitalized with COVID-19, showed that 46% of them had comorbidities with which we're very familiar, at least in the HIV setting, because they involve hypertension, cardiovascular disease, diabetes, and other illnesses. Of note in that study, it was small, it was only 138 patients, but chronic liver disease was only seen in about 2% of people, and HIV was only seen in 1% of those 138 people. But comorbidities does seem to be a key factor for predisposition to acquiring the illness. Other factors remain unknown, and you'll see them out there. There's concern that in fact some of the medications that are used to treat diabetes, hypertension, and heart disease may potentially predispose individuals to acquiring COVID-19 by increasing the levels of the receptor that the virus needs to invade the body. And in fact, even some of those illnesses are associated with increased receptor expression, even if they're not treated. Other things such as smoking, Andrew may touch on, and gender, whether there is a gender imbalance or not, whether those factors, what role they may play remains unknown, as does the role of non-steroidals, which you'll see floating around in the broad media. If we turn to death, the case fatality rate for COVID-19, which is defined as the number of deaths in people who are diagnosed with COVID-19, is around 2.3%. Another way of determining fatality is the infection fatality rate, and that's the number of deaths in all cases of COVID-19, whether they're diagnosed or not, and that's lower at around 1%. But to give you some perspective, the death rate from influenza in the US either last year or the year before was around 0.1%. So thankfully it's not as serious as MERS and SARS, as Sharon said, but it does appear to have a higher infection fatality rate than, say, influenza. What predisposes people to death? The answer seems to be age, with higher death rates in older people, having critical illness, being in ICU with a death rate of around close to 50%, and the case fatality rate is higher in individuals with the comorbidities that I mentioned earlier, cardiovascular disease, diabetes, and lung disease. So they are the key features that track for a higher risk of death. As Sharon said, most treatment is largely supportive. Fortunately, a large proportion of people can be managed at home symptomatically. Other patients will need hospitalization. And as Sharon said, a number of novel therapeutics are being studied. There is a paper that's come out in the New England Journal this morning from China where 199 people were randomized to receive the lopinavir, the Kaletra drug, lopinavir ritonavir, versus standard of care. And there was no difference in the primary outcome of recovery, discharge, or mortality. So that's an early signal perhaps that Kaletra may not work in this population. Mind you, they were hospitalized. I want to emphasize that there's no evidence that the drugs used to treat HIV or prevent HIV can either prevent or treat COVID-19. So I know some discussion is going around, but there's no evidence for that whatsoever. We do have access to the drug from Gilead that Sharon mentioned, remdesivir, a nucleotide analog. It's special access, it's intravenous, and it's only people who are hospitalized and on a ventilator in intensive care can have access to that drug, but we technically do have access to that in Australia. So I want to turn now to HIV infection and other bloodborne viruses and COVID-19. What do we know about the relationship? Does having one of these bloodborne viruses make you more vulnerable to infection or having poorer outcomes? I've only been able to find one case report about a person who diagnosed simultaneously with looks like advanced HIV and COVID-19, which became quite severe in lung infection in China. It was in the Journal of Medical Virology. That person survived. And there, in that case, in those 148 patients I mentioned earlier in the JAMA paper from China, 138 patients, only 2 of those were HIV positive, and they didn't seem to have an untoward outcome. It doesn't look like it looks like they survived. There's no evidence that being HIV positive per se puts you at greater risk of this virus. But I think we need to be sensible and understand that people, the 11% of Australians who are not diagnosed and who may have low CD4 cells and are not on treatment may be more vulnerable. There's no evidence yet that people on treatment with still remaining with low T cells on successful treatment are more vulnerable, nor do we know whether people with AIDS illnesses in the past on treatment are more vulnerable. That is all to be uncovered. But we do know what the general community experience has shown us, which is that age is a factor. And in 2017, a Kirby report told us that close to 50% of people living with HIV in Australia were over the age of 50. And we know from a number of different studies done in different ways in Australia that older Australians living with HIV are encumbered with having to live with the comorbidities that are associated with a greater risk of infection for COVID-19 and a greater risk of having poorer outcomes. So I think that's probably the message we need to absorb now. I just want to foreshadow that as you all know and would guess anyway, socioeconomic disadvantage and people who are deeply stigmatized, and stigma itself, are likely to play a very large role in the future pandemic because of crowding and inability for social distancing, etc., and poor access to healthcare. And this especially pertains to Indigenous and homeless populations. I wish I did have more, but I haven't found any evidence so far that there's a relationship between greater risk of infection or poorer outcomes with other bloodborne viruses such as hepatitis B and C. And just want to emphasize that in that study from China of the 138 patients that only 2% had chronic liver disease. So I'm not quite sure what that means, but I think it's just something we'll have to watch that will emerge. The data will emerge. Finally, I want to address challenges, and broadly, I think the challenges for us to be able to test and treat people with COVID-19 will really greatly challenge our health system, our health workforce, and the populations that we care for. And there have been some projections that suggest that 20 to 60% of Australians may acquire COVID-19. That could potentially translate to 50,000 to 150,000 deaths over time. So to turn more specifically to people living with HIV and other bloodborne viruses, they will definitely have immediate changes in their routine healthcare visits to their GP or outpatient outpatient clinics in hospital. Less frequent visits are likely, increased visits, increased telehealth and telephone consultations. Worryingly, they will have difficulty seeking, I think, getting appointments for acute illnesses, even say for influenza, for example, or ischemic heart disease, etc. There will be some challenge getting acute healthcare for non-COVID related illnesses. And of great concern is the increasing risk of social isolation in people who are already potentially very isolated living with HIV, especially people who are older living with HIV and other bloodborne viruses. Of note, people living with HIV and other bloodborne viruses who are Indigenous or who are sex workers or from cold communities, people who are injecting or Medicare ineligible people may find it very hard. This is to me of great concern to have receive consistent and accurate messaging around COVID-19, and also may find it very hard to actually achieve appropriate social distancing and quarantine measures. And it will be challenging to adapt to differences in healthcare access to healthcare and affording healthcare, and with job losses and as Darryl mentioned at the very top, sex workers who are not doing virtual sex work may in fact have immediate job losses and issues there. So this is a real issue, and these considerations apply to people not living with bloodborne viruses, but who are vulnerable to bloodborne viruses. Finally, with the healthcare workforce, I think the first point is that keeping our healthcare workforce, and here I'm thinking of all the scientists at the Doherty Institute, in Vigil and all around Australia and the world, doing the diagnostics, the nurses, the allied health workforce, and doctors in hospitals and outpatients, keeping them healthy in terms of preventing COVID-19, and their general physical and mental health is really vital. And to achieve this, I think we really need to prioritize the knowledge around how to prevent COVID-19 in different healthcare settings. What does it look like as GP? What does it look like when you're doing a nursing home visit? What's it like in a hospital outpatient? We need to have very clear messaging about how to prevent COVID-19. We do need to prioritize our COVID-19 future treatments and vaccination opportunities for our healthcare workforce, and increase the workforce and upskill the workforce for diagnosing and treating COVID-19. And then to keep a very high level of healthcare, which Australia delivers and is well known for delivering such a high level of healthcare, to make that ongoing to our populations, we really have to rapidly make changes to our workflow practices, deliver high-level messaging to our patients, ensure that people living with HIV and other bloodborne viruses are able to enroll in appropriate clinical trials, and very closely involve the sector, the HIV and bloodborne virus sector in this process. And with that in mind, I want to say that ASHM is developing and will lead a COVID-19 task force to address the needs of the healthcare workforce and the populations of people living with HIV and bloodborne viruses and those at risk of the viruses, to optimise the delivery and the quality of healthcare and appropriate research to people during this pandemic. And Alexis Apostolellis, the CEO of ASHM, will address this a little later towards the end. So thank you for your time and attention.
Edwina, thank you so much, and particularly that's a wonderful announcement to hear that ASHM will be leading that task force. Great news. I want to turn to Andrew shortly, and we'll come back for questions and discussion at the end. But just one quick question, Edwina, in terms of people treating for Hep B, for Hep C, or for HIV. Is there anything that they should be thinking about in terms of adjusting or changing or stopping medication?
No, I don't think so at all. And especially the concern is, will people receive messaging around those treatments for hypertension, diabetes and heart disease? Are they putting me at risk? That is simply unknown. And just to throw something into the mix, there's even postulation that some of those drugs may be useful in treating SARS infections. So absolutely no change whatsoever. It's better, as you've already mentioned, getting in to be vaccinated for the flu in time, and pneumococcal vaccines, being on PrEP for people who are vulnerable, and seeking other key healthcare measures. Needle exchange must keep going on, etc. For maintain other healthcare measures. No changes in that space.
Wonderful, thanks, Edwina. And on your mention then of needle and syringe program, it's one of the things that I'm most concerned about. We not only have to live through and navigate COVID-19, but we have a HIV, a bloodborne virus, an STI response that needs to be maintained. And needle and syringe program is one of those critical pieces of public health infrastructure that all of us have to be concerned will be sustained through this. Andrew, over to yourself. Professor Andrew Grulich is from the Kirby Institute, and we really wanted to sort of segue from the research and the clinical to then think more about the public health and the epidemiological aspects of this, and once again with a particular focus on our communities and what we should be thinking about as clinical and community sector workers and leaders, what this might mean for us in our practice. So over to you, Andrew.
Thanks, Darryl, and I'll start by giving the apologies of Professor Raina McIntyre, who would have liked to have given this talk today, but she couldn't be with us today. So to start with, what is public health trying to do in trying to respond to this epidemic? I mean, you're exposed to these messages every day, but we should have this conversation through the lens of our communities, I think, very much. So firstly, I should say that these interventions are all based on mathematical modelling, and the mathematical models are completely imperfect. They are a lot better than nothing, but we really do have to read the sort of assumptions they make before we pay too much attention to them. So when you read, for example, that 60% of the population will get this virus, 60 to 80% is the actual estimate who will get this virus. That's in the absence of any intervention. And so, when you see those figures, that will not happen because we are intervening. The question is, how much lower can we drive it? And the driving force here is not so much to reduce incidence of infection to zero, because that is very difficult, but to get the incidence of infection low enough so that it doesn't exceed the capacity of our healthcare system. And that's can seem a very vague outcome, but it's essentially, because we know this ends up with a relatively known proportion of people in intensive care units, we have to be very sure that limit is not overcome, and otherwise you get the horrible scenes that we've seen in China and Italy presenting. So that is the aim. And so how do we do that? So firstly, social distancing, which is keeping ourselves relatively separated from others. 1.5 metres is the government guideline. No touching is clearly essential. No touching other people, apart from in your immediate grouping. And that is obviously going to be a very important message for us to give to sex-positive communities such as young gay men, for example, who have got used to messages from us saying in the past, it doesn't matter how many sexual partners you have as long as you use a condom, and now the message tends to be it doesn't matter how many sexual partners you have as long as you use PrEP. That is not safe for transmission of this virus. This virus can be transmitted through touching. It's certainly, it's not conventionally a sexually transmitted infection, but you're obviously kissing and touching a person, and that is very high risk for transmission. It's going to require some very careful messaging. The response in China was also based largely on isolation and quarantine. So the difference between those two, in that isolation refers to people who are sick and quarantine refers to people who are well, who may have been exposed to the virus. So an isolation of a case is putting them in a place, generally a hospital, but for people who aren't terribly well, this could be in their own homes, so that they don't transmit the virus to others while they are sick, and for the period afterwards where they might still be transmitting. And it's a much longer period than it is for influenza, and so the current guideline is for a 2-week period of isolation, and the same with quarantine. So people potentially exposed, so all of those people who are currently coming back to Australia are being asked to stay at home for 14 days to ensure that they don't that we don't have another generation of infections leading from them. Those interventions may need to be supplemented by school and university closures. Now, that's mostly from our knowledge of influenza epidemiology, which is clearly very strongly influenced by transmission in children, and not only among children, but from children to adults and then onwards. This virus, as you've heard from Sharon and Edwina, doesn't affect children from a point of illness as much as adults, but infection is still relatively highly prevalent. So that is part of the complexity about this current decision that Australia is struggling with about whether to close schools and universities, in that it does seem to be slightly less important than it is for influenza, but it's certainly likely to be part of the equation at some stage. So where does that leave us if we do all that interventions? Well, and the good news is that places like China have shown us that those sort of interventions can drive down new infections virtually to zero. So remarkable what's been done in China. But you will have seen, many of you will have seen some quite disturbing videos online about the degree of force that was required in China to keep people in their houses, to stop them going out and getting close to each other. And those options are obviously not open to a society like ours. But on the other hand, with good public education, we should be able to get people really practicing social distancing well without the need for those interventions. So that they can get the number of infections and deaths right down. The problem is, and this is the one that really we have to grapple with, is that once you've done that and you've got no infections, as soon as you take your foot off the pedal, the infections will return. So, you can have the sort of lockdown you're seeing in Europe and parts of the US, and that should do a great job. The question is, what then? Of course, an important part of the what then is massive investment to try to get us a vaccine and treatment, because those medical interventions would then render these social interventions less important eventually, but really for quite a while. Some of the modelling speculatively has suggested that you could have periods of slightly less intense interventions and then more intense over a period of a year or so, if that were required, to get us towards a vaccine. And really, I'd finish just by saying that much of this is speculative. It's very hard to model the complexities of human behaviour, and we're learning every day. So with that, I'll open it to questions, I think.
That's great. Thank you so much, Andrew. Okay, so let's open to questions. Just before we go to general discussion, and we've still got Edwina and Sharon with us, can I just check first, are there particular questions that people wanted to highlight for Andrew? If you want to put them through in the chat function, or if you just want to signal to me, unmute yourself and ask Andrew a question, please feel free to do so. Okay, so Andrew, just from my end, you know, I was struck by your comments on, you know, the appetite in Australia and Western democracies for the more coercive measures that might be required to really, you know, achieve social distancing at the levels required. You mentioned that education could really help here, but I do wonder, you know, if we're needing to do something, if we're needing to have a sustained response to COVID-19 over 6, 9, 12 months. You know, I have a question in my head about how realistic it is to expect that we're going to be able to achieve the level of social distancing that would be required to really drive down these infections.
Yeah, look, I think you're right, Darryl. We're in completely uncharted territory, of course, and that's where you hear people arguing, like the UK started to talk about herd immunity as a response to this, and that was the theory that once you got enough people infected, that this would disrupt the transmission of the virus. The trouble is, through doing so, you would have an immense wave of mortality in the high-risk group. So it's not something that we're currently prepared to entertain. But if you had a pattern where you are having intense periods of intervention, perhaps with several weeks of less intense intervention between those periods, then gradually the number of infected people would increase, but by far less than just by one, you know, when you don't intervene at all, then the infection rate over the next 2 to 3 months becomes the 60 to 80% of the entire population. That's what we've got to avoid. So having short, sharp bursts, if it's going to last 12 months, might be something we have to experience.
Wonderful. Thanks, Andrew. So please signal to me if you'd like to jump in now with questions to any of the speakers, or if you'd like to make a comment, just let me know and I'll so I can manage the order of discussion. Robert Grew, who I should have acknowledged at the beginning, is AFAO's president. Really great to have you on the line, Robert. Do you have a question?
Thanks, Darryl. So it's a sensitive question. It's a question I've been asked by people from boards of some of our members about discussion in the community about gay venues. And I'm just wondering if, Andrew, you wanted to, without putting you more on the spot than I inherently do by asking you, give us your view about the advice that organisations should be considering passing on through communities.
Yeah, I was having a discussion with a colleague this morning about this very question, Robert, and it's a really concerning one. On one hand, we absolutely want to avoid the sort of anti-gay hysteria that we saw with HIV, and on the other hand, we want to make sure we protect our communities. So I think there's a different response for gay pubs and clubs, because they are no different from straight people's clubs and pubs with relation to the transmission of the virus. So that the venues we're talking about are sex venues where people go to have sex. You can't have sex without touching people. Sex for transmission of these viruses, well, you can have, but in terms of these places, you go in there to touch people and have sex. So I think these are very high risk places. For transmission, it's an incredibly difficult conversation to have, but I think we really should have an informed debate about whether we need to ask those venues for the good of the community to close down for a while. There's an equally complex debate that we need to have about sex work, because sex work that involves touching each other, very high risk for transmission. As both Sharon and Edwina said, a reasonable proportion of transmission appears to occur from asymptomatic people who don't know they have the infection. And in that setting, these are very high risk situations.
Thanks, Andrew. And I'm actually seeing some comments on the chat about the specific implications for sex workers. You know, in addition to those broader comments you made about sex venues. Can I throw to Alexis at ASHM?
Super, thanks. Thanks, Darryl. Trying to work out the technology. Just in some comments on some of the questions that are coming through in respect to ASHM's role in terms of convening really the sector in terms of more the clinical side, but also the social side. I think we completely agree that stakeholder engagement is crucial at this time. And we're committed to working in collaboration with everyone. We think there's a clear need for some work in research in terms of advocating for people living with HIV, chronic hepatitis and C to be included in clinical trials in prevention of SARS-CoV-2. Really to look at monitoring the incidence and clinical outcomes. We think there's a huge need for clinical guidance in terms of our clinicians. We're getting a lot of questions just in the last day or two, and it was discussed at the ARV Guideline Committee the other day in terms of the need of developing these guidelines for clinicians and the community on things like PrEP, on all the things that Edwina did already mention, but people are asking, and we think a task force is needed urgently, and we are talking to the Commonwealth about getting this out, particularly around the vulnerable populations, which we know are going to be excluded when the kind of the mass herd kind of move in and other priorities take place. So absolutely, and we want to roll out this type of training, and it might be through different modalities than usual in terms of Skypes and tweets and emails. We also think there's a good link into the conference later on in September, which is obviously still in debate about how that'll work out. But you know, a particular session on this and bringing it all together is essential. So we welcome the opportunity to work with all in getting this moving forward.
That's great. Thank you. Thanks, Alexis. Can I just throw to this question? We've got Edwina, just on a technical question. You mentioned before close contact. Could you just walk us through what we mean when we're talking about close contact?
Yeah, sure. So our working definition based at the Alfred Hospital, so the working definition is that a close contact is where you have face-to-face contact with a symptomatic, proven or suspected, a person who's symptomatic with proven or suspected coronavirus for 15 minutes. So that's face-to-face contact. Or you have contact with blood or bodily fluids. Or you spend 2 hours in a confined room, not face-to-face, but in an enclosed room for 2 hours, and you are not wearing personal protective equipment. So you're not covered up at all. 15 minutes face-to-face contact or exposure to bodily fluids, or 2 hours in a confined room with a person who's symptomatic and either proven to have or suspected to have COVID virus. So that's close contact. That's the definition that we're using, which I think is really sensible given the nature of the virus, that it's droplets, it's spread via droplets. There's no hard evidence at all to show that it's spread by air up in the air and we're just breathing it around. So it's about contact, proximity.
Excellent, thank you, Edwina. And just while we're with you, I just had another question, which is just asking about the differences in death and complication rates in other countries, and if you could just explain that for us.
Well, yes, I think that's really important, how we frame messages. So as Sharon started out giving us a very big overview, it's about framing the messaging and understanding the nuance. And I can see nuances coming up now in the discussion around different people at risk. So, for example, the vast majority of the data have come from China. There are over 44,000 cases of people with confirmed coronaviruses, and they also had working definitions of people who weren't tested but they thought they were likely to have coronavirus. So they've got several thousand people that they've seen the virus in. So how different is China to us? What's the difference in terms of socioeconomic status? Smoking rates, for example, are very high for men smoking in China, much less so for women. What is their nutritional status? What was the level of healthcare that was available to people in China compared to a country like Australia, which is arguably has the leading healthcare system in the world? All of that needs to come out. the death rate, I haven't seen, I keep looking for data on early publications coming out of Italy. There'll be a little bit of time before we hear from a country like Europe and then other high-risk countries on how their outcomes are. I imagine they may well differ according to the country and the locale. And that's why, I mean, there's a cause for optimism that we're so fortunate to live in this country, but we need to just keep watching and learning.
Wonderful. Thanks, Edwina. And to our speakers, but also to the other experts that are on the call, you know, as you see those chats coming through, feel free to respond to them using the chat function. There's questions that people are asking. If you've got some information, please share that. I just wanted to unfold, and there's a question really to Sharon, Edwina, and to Andrew, just to unfold this question about social distancing and sex. And we've seen some comments there, you know, particularly for sex workers. Yes, we know what social distancing means. We know what public health would ask, but then there's reality. And if we're talking about a sustained response, then for sex workers, it's simply not realistic for us to expect that sex work is going to stop. So is it possible for us to imagine, I don't ask you to make up answers that don't exist, but is it possible for us to imagine ways in which sex work or sex with you know, other partners, with casual partners, if you like, that can be had safely from a COVID-19 perspective? Or is there risk minimisation that we could be imagining in the context of a COVID-19 epidemic, where you could be sitting at a table with sex workers to try and work this out? Is that something that's possible?
Darryl, I'll give you a biomedical response. I think some of the consultatory things are your field rather than mine. But sex for transmission of this virus will be very high risk. But sex workers are not the only people who are very adversely affected in that way. Live musicians, for example, they are just going to be out of a job for the next year. So, you know, obviously, there are online forms of sexual expression which some people might maybe to earn some income, but our discussion, I think, and that'll be up to the creativity of sex workers probably, but our discussion, I think, should focus on how can we make sure that when the government is talking about compensation packages to various forms of workers, that people like sex workers are not left out.
Exactly.
Yeah.
And to that, Andrew, really good call. And I was on an ACOS CEOs meeting earlier on, and you know, I made that point for people in our communities who are going to be very hard to hit. There needs to be that needs to be looked at.
Darryl, it's Sharon here. Sorry, because I'm going to have to drop off, but I completely support what Andrew just said, and I've been, you know, sort of heavily involved in discussions of what China's doing. You know, the best case settings with Singapore, Hong Kong, South Korea, Taiwan. You know, I have never heard this discussed, and it's obviously a big issue everywhere. Everyone has sex everywhere. Sex workers are an active professional group, so a loud voice on it from here would be really welcome.
Well, and while we're all going stir crazy at home for the next who knows what that's going to do in terms of online and other activity. Edwina, did you want to comment on this?
Yeah, I did.
And thanks very much. I'm going to go. Sorry.
Thanks, Sharon,
everyone.
From all of us. Really appreciate it. And to echo Edwina, well done and stay well with all of your work.
Thanks. I just wanted to say I completely agree with Andrew that well, first of all, I think sex workers should be sitting alongside the science and in guiding us, number one. And Andrew, I'm sure, feels the same. So, because I'm not a sex worker, I don't know how it works. So, and I don't know what I need, but we need the people to tell us. The second thing is that I completely agree with Andrew that there has to be equity. These are people who just work for a living, they should be considered in exactly the same way that casual workers are being considered, with great empathy and consideration around Australia. The third thing is that there is also an onus of responsibility, because it's largely men, on men in our community to understand that they're putting the sex worker at risk and themselves at risk. And just like there was that funny tweet that came out of it, well, if it really did, maybe it was just made up, but from a police department in the US saying, to all criminals, could you just kindly consider, stopping crime for a while, resume as needs be when the epidemic's over. But I do think there has to be some messaging around making it equitable and bringing us back together into the mix of this illness, because without us all being together, it's massive. We can't beat it without making everyone sit back and reflect on their behaviour.
Yeah. Wonderful, thank you, Edwina. Just before we close, I want to just throw to Kevin first. Kevin Marriott from Hepatitis Australia. Just ask if you've got any closing remarks you'd like to make, Kevin.
No, well, nothing specifically. I mean, this has been fabulous to sort of hear these comments and get a bit of clarification around some of this. I mean, clearly there's huge implications for all of our communities within this, and clearly I hadn't actually thought about the stuff around sexual transmission, but obviously something that we need to take note of, and getting this information out to our communities I think will be very, very important. We just need to do that in a very delicate way. So thank you all.
Thanks, Kevin. To Alexis, any closing remarks from your end?
Yeah, super. Thanks, Darryl. Thanks, Kevin. Just two things. Is one, a very big thank you to the speakers, Edwina, Sharon, and Andrew, very much, and Darryl and Kevin for putting this together as well with us. I think I'd just like to point out that we will be sending out a sector communique, and this is really hot off the press in terms of the development of this task force, as I mentioned, and really will be reaching out in terms of consultation and developing the terms of reference from all the groups on this call and beyond.
Thanks, Alexis. Robert, to you for AFAO, are there any closing comments you'd make?
Thanks, Darryl. I'd like to underline the thank you to the speakers. There's 100 people online, and I keep getting emails from people who weren't able to get in. So just to reassure, and for people who come across those who weren't able to get in, we've recorded this and I presume we'll be making it available. So look for it, or if you can't find it, get them to contact AFAO or ASHM or Hepatitis Australia, and we'll do that. Other thought is that information is going to be key, and the organisations will keep working together and pushing information out. But for all those who've joined in from the front line, do please keep asking questions and giving us feedback. I think there's a particular challenge of doing this in isolation, so we're going to double down on community and communicating. And the third thing I was going to say is there's a whole lot of questions people asked in the group chat, and if you haven't gotten an answer, then don't lose the question, do ask it. And there's also several advocacy imperatives that people have raised. Sex work and the situation of sex workers has come up, but there are others in there too. He certainly was those. Darryl's, as he mentioned, been in contact through ACOS, through the community sector, and we will be also working with NAPWA and other peaks to keep pushing the advocacy messages that we need to. And to Darryl and the others, look, thank you for organising this, Kevin, Alexis. It's been really, really useful, I think.
That's wonderful. Thank you, Robert. Just in terms of AFAO's members, we're in close to daily contact with all of our members. A real shout out to NAPWA, to AVIL, and to the Inukana National HIV Alliance and Scarlet Alliance in terms of the leadership that they're taking with their communities and members. And also to the AIDS councils in each states and territories. Like, all of us as organisations, as communities, are really pressured, and this is demanding of us things that we've never experienced before. The way in which I'm watching people professionally and personally respond, I think, is admirable. But there's a lot of work for us to do to adapt, not only to COVID-19, but actually to sustain the HIV, the viral hepatitis, and the STI response. We can't lose that, even while we're grappling with this massive additional issue that's in the room. So thank you everyone for joining. Thank you for being so behaved. 100 people on the call, hard to manage. You've done a great job. Thank you for that. We'll keep those questions. We'll share the video. Edwina and Andrew, particular thanks to you, and everyone. We will stay in touch because it seems like there's a real need for us to do this. So let's think about doing it regularly as we step through the coming months. Goodbye, everyone.